All right, I think we'll go ahead and get started. Welcome, everyone. Thank you all for joining us. My name is Sue Huang. I am the head of data strategy at Datavant, and I will be your moderator for today's webinar. Today, we have guests from Blue Health Intelligence joining us to discuss their data assets and analytic capabilities. We will discuss use cases that their data can support and deep dive into a research study using BHI data that highlights insights from the intersection of behavioral health and chronic medical conditions. Joe Bisson is VP of Business Development at BHI, and Dr. Fareed Alam is Director of Clinical Analytics at BHI. I will turn it over to them shortly to provide introductions. Throughout the presentation, if you think of questions, you can submit them through the Q&A box in Zoom, and we will answer questions at the end of this presentation, time permitting. Joe and Fareed, thanks so much for joining us. Can you please introduce yourselves?
Hi, everybody. This is Joe Bisson. I've been working with BHI for about 9.5 years now. I work out of our office in the Baltimore area, and it's great to be here today.
Thanks, Sue and Joe. My name is Fareed Alam, Director of Clinical Analytics at Blue Health Intelligence. I've been at BHI for a little less than 3 years, and I'm based out of the Chicago office. And thank you all for joining today.
Thanks for those introductions. I'll turn it over to Joe for the first half of this presentation, which will be to provide an overview of BHI's data and analytic capabilities.
Oh, well, thanks, Sue. I'd like to just thank Datavant for putting this together today. We started partnering with them sometime last year. We've got our first couple big projects underway with them, with linking with other partners. So very exciting addition to our capabilities at BHI. For those of you who are new to learning about our company, I'm just going to spend about 6 slides, describe who we are, what we do, and some of these slides we use in our normal sales, but I'll try to keep it very informative. I'll probably spend 10 minutes and we'll get over to Fareed's part very quickly. But way back in 2005, about 15 years ago, a lot of the Blues put all their data together, claims data. They needed it all in one place to respond to big national self-insured employers. They had very strong analytic needs. The individual Blues are not allowed to share data, so the Blue Cross Association turned out to be the perfect hub to put all that data in one place. And they had spent a lot of resources putting that all together, and they finally realized around 2010 they were sitting on a very highly valuable data set. So fortunately for us in the market, they spun us off at that time as an independent company. Our mission was to continue to support the Blue Cross Association, to support all the individual Blues, and to support what we call the external markets, everything outside the Blue Cross system in the healthcare market. So currently we're still owned by the association and a big number of the Blue Cross plans. We're an independent for-profit company. The core of our capabilities is that big national database. And I'll get in a little more of what else we do as a company. But when we started, all we had was that data, and then we quickly added a layer of analytics that we can support to the industry or provide to the industry. And we've added some software platforms that I'll talk about briefly today. We're headquarters in Chicago, as Fareed said. We have an office in Tampa, Florida, and one in Baltimore. And we have people throughout the country. Our customer base varies quite a bit. For the association, you may be aware of some of their national initiatives. They have an NCCT transparency program. They have a Blue Distinction high performance provider program. And they have a Health of America report series that they put out quite a bit. We serve as the analytic engine behind a lot of those initiatives from the association. And that's a big role that we play as a company. We also provide, as I mentioned, analytics and software that we license back to the Blues like a lot of other companies do. We have predictive models. We have a software platform for employer group reporting and provider analytics that the Blues use. We have software that optimizes care management so you can stratify in the most actionable patients, things like that. We have a platform around maximizing revenue for MA and ACA programs. So that's a big part of our company right there. And then around the rest of the spectrum here, we work with all other types of industry segment individuals. The academic institutions, there we do more of collaborative work with them. Sometimes we'll do a joint publication on a topic. We work directly and indirectly with a lot of the federal government agencies. For a long time, CMS has been using our data to train their actuarial models for their ACA program, and FDA and CDC are users of our data. So those are nice rubber stamps of the integrity and reliability of our data. In the health system market, we have some partners that serve all the hospital systems around the country, and they embed our data into some of their offerings. We're very open to a mix of direct customers and business partners or channel partners or collaborative partners, many flavors of partnerships. We have some direct relationships with the hospital systems as well, but a lot of that is, as I said, through our partnerships. A big part, it's hard to describe in 2 words, but what I call health analytic companies, all the other companies that you all represent that serve these other industries. And a lot of these companies have an intervention solution or a care management solution or predictive models or some sort of program that serves those market segments. And they'll leverage our data in a lot of ways to demonstrate the effectiveness of their programs to the market. The life sciences is a big part of any healthcare spectrum. That includes the pharma companies, the med device companies, and related entities. And there's a wide range of uses there. And then there's another bucket of just professional services. We work with private equity firms, a wide range of consulting firms. And again, a lot of times there, we're helping them serve their customers. I have one slide here with all the bullets and words, but just to help you everybody see what we have for data. Data can mean a lot of different things. And I know a lot of the audience has worked with different types of data and even claims data over time. We cover medical claims, prescription drug claims, and enrollment data from most of the Blue Cross plans. The enrollment data is very important for any study where you want to make sure you're filtered on people that were enrolled over a certain period of time, or exclude certain people, or build a selection criteria of patients that had this diagnosis along with these other medications, whatever it might be. The data is updated every month. We provide either licensing of the data or summary tables that some customers need, or we do analytic studies for a customer around that data. It's made up of the commercial population. The Blue Cross plans are contributors. They submit both their local and national members. So that gives us great coverage in every nook and cranny of the country. We've got population in every zip code. There's obviously greater density in some geographies than other, but that's a big part of our offering. And what we've found useful is we have a nice mix of coverage between individual members, smaller, fully insured employer groups, and large self-insured employer groups. And slight differences in what you might find in those subpopulations. And what you'll see is we have all the range of services from facility claims, professional claims, prescription drug claims, most of the things you expect to see in claims data, multiple diagnosis codes, procedure codes, all the NDC values, a lot of other prescription drug data elements. We have provider IDs and other provider attributes like specialty codes and so forth. We have the whole tree of dollar fields and place of service, types of service, things of that nature. We follow, everything is HIPAA compliant, de-identified data, and we also follow some rules given to us from our owners. So, there's certain data elements we sometimes cannot mix and match, but that gets flushed out in any partnership discussion. All the unique patient IDs can be linked across type of claim, type of service, or date ranges, so you can follow the same patient over time. One of the things I mentioned was the consistency and reliability of this Blue Cross data, the Blue Cross population itself. So in any study that you're working on where you want to look at the effectiveness of a program over 2, 3, 4 years, or you want to build a predictive model and the continuous enrollment of the underlying population is important to what you're trying to do. We have very strong rates of continuous enrollment. If you start on a day one of an index date and you follow for 3 years, you still have 45% of those people continuously enrolled over that whole period of time. It obviously gets smaller and smaller as each year goes by. But the reason why we have very strong rates here, our data contributors are perpetual in nature. So it's not a moving target. They're not coming in and out as a contributor. That consistency has been a big factor. And I'm not, I've never worked for a Blue Cross plan, but they tend to have very good member retention rates. So those two factors together give us these good rates of continuous enrollment. And I think I just have a couple more slides. We are adding to our library of enhancements that we can place on top of the data in certain cases. A lot of our clients are doing more work now factoring in social determinants of health. So if I want to compare the performance of two cohorts of people, I can better adjust for those populations using social determinants data in my analysis. So that's an option that some people value quite a bit. We have built our own episode of care grouper over the last several years. We had used all the industry groupers that are out there for decades now. And what we came up with was something that took care of all the things we wanted in those other groupers. It covers hundreds of episode categories. Some are condition episodes like pneumonia or knee arthritis, and some of them are procedure episodes like a knee replacement. So you can actually have a procedure episode of knee replacement within a condition episode of knee arthritis or knee OA. So that grouper information can be appended to the data model or to within a study or whatever else we're working on with a customer. We've also added in a standardized cost field where sometimes the true dollar fields might be sensitive for a certain thing. The exciting part about this capability is that it actually washes out differences due to provider contracting. So one provider or treatment of care might look more expensive. It just might be they had a better provider contract. So it washes all that out, and it really looks at the efficiency of care. So if one course of treatment is providing a lot more tests and things like that, and it might show up as less efficient, meaning a greater standardized cost value. And finally, we have a tool of our own as well called our CarePulse quality engine, and it can create any of the standard quality measures that are out there in the industry. And what we really like about it, it can create any custom quality measure anybody could dream up where you need numerators and denominators, and we can package that into a project or a set of data. We're adding to this library as we go on, but these are some of the core elements we have so far. And this would be my last slide, but I just wanted to give you an example of some of the use cases that we support. And over hundreds of projects, they all look a little different, but in my mind, they fall into 4 or 5 categories like this. The first one is probably the most prevalent. You want to demonstrate the effectiveness of your product or your intervention. If I treat a patient with my product or my course of treatment, I want to quantify the effectiveness of that. And why do I want to do that? I'm trying to demonstrate the power of my solution to my target audience, my target customers. So that's a very dominant use of our data. And that's where the continuous enrollment comes into play to be very important. I want to build multiple 2 cohorts of population to compare, and I want to track them over time. Usually I'm measuring the total cost of care between 2 groups or across 2 groups, and I'm measuring any outcomes or differences in outcomes between those two groups. Another category is training a predictive model or educating a predictive model or any sort of model that the data, I view our data as rocket fuel inside of an engine and to make it stronger. And we use our data to train our own models. We have a wide range of predictive models. We have customers that, like we are, they're building models to predict who are going to be the high cost claimants next year, or who are going to have disease, who's going to have the greatest disease progression in the following year. Any of those things, the data is great at, training them on a regular basis. Populating a product is the third category here. And we have business partners that offer software products to the industry. And our data will be used to activate metrics within those products. And that's where we have very nice partnerships. Some of our partnerships are 7, 8, 9 years long, and we're very proud, very proud, and we highly value those partnerships. But it speaks to the consistency of what is provided in this data over a long period of time. Market profiling is a big umbrella, but a lot of people just want to look at, by geography, what's the prevalence rate of a certain population or disease or use of a product across geography, prevalence rates, trends. I want to look at where should I target my business growth? Should I expand my business in oncology or orthopedics? What's going on across the market? And we can look at 5-year trends, 10-year trends, geographic distributions, you name it. So that's a pretty wide umbrella. Another wide umbrella is provider performance. We have some customers that are providers themselves, and they just wanted to demonstrate the effectiveness of their intervention, as I mentioned earlier. So we have one partner that they have a different course of treatment for orthopedics patients, and they're trying to minimize unnecessary MRIs, for example. They're trying to minimize walking in and getting a surgery right away, where maybe some form of physical therapy can be done instead. We do a lot of work ourselves with the health plans on their collaboration with their providers in their network on measuring performance. So that's a very big topic these days for a lot of reasons. If you're entering a value-based care arrangement, do you have any inefficiencies that would get in your way? There's a lot of things we can measure there. So I'm going to pause there. That's an overview of BHI, who we are, how we work with people. And hopefully I did that in a way that's more informative than trying to sell anybody things. But I appreciate that so far, and I'll pause there.
Joe, thanks so much for that great overview of BHI and what differentiates your data. Before I dive into some information about how BHI and Datavant work together on data linkage projects, I'd like to take a poll of the audience at this point. For research that you have conducted with claims data in the past, what are some attributes of the data that you wish were stronger? You should see a poll pop up in your screen right now, and you can select up to 3 attributes. Results will show up for the whole audience. Okay, Not sure what's happening with the poll. I think we should move on and maybe we'll come back to this later on. Oh, all right, there's the poll results. Just took a little bit longer than normally does. So looks like a lot of people have selected the lack of continuous history as an attribute they wish were stronger. Insufficient granularity in data elements also got 38% of the votes. And down at the bottom, data not linkable to other data types got 49% of the votes. That's great to hear from a Datavant perspective, and leads greatly into our next section where I'll give an overview of Datavant. Thanks everyone for participating in that. So I'll give a quick overview of Datavant and how we enable partners like BHI to link their claims data to other data types, creating a more patient, complete journey. So Datavant's vision is to connect the world's health data to improve patient care and healthcare delivery. Data is more fragmented than it has ever been in the healthcare industry, and the pace of generation of new data is only accelerating. There's a lot of interesting data out there, and there's more analytic power than at any point in the past, but the data remains hard to find and siloed across many organizations. Our mission at Datavant is to break down these data silos. So how do we do that? Datavant software enables on-premise de-identification of data behind an organization's firewall so that PHI doesn't ever have to leave your environment. The software utilizes a patient's identifying elements to create HIPAA-compliant patient keys, which can be used to match health data about the same patient across multiple organizations. Our software also applies a unique encryption key for each organization so that my records aren't matchable across organizations automatically until those organizations decide to partner and establish a link. Only after a link is established will my records at the organization on the left, where I'm represented as patient 123, be matchable to my records at the organization on the right, where I'm represented as patient 456. This is a key security feature of the Datavant network. Through the application of Datavant, we have enabled various data linking use cases for BHI. One use case is to deduplicate patients between multiple claims data sets so that there isn't double counting of patient populations when conducting analysis on aggregated claims. Another use case is to enable BHI claims to be linked to other data types like EHR or lab data for a more complete picture of the patient. Data linkage across disparate data sets is only as powerful as the size of the network. And I'm happy to say that Datavant software is deployed across hundreds of sites to enable our partners to connect to the nation's largest ecosystem of real-world data. We cover a broad spectrum of data types from claims data, such as at our partner BHI, to EHR data, lab data, mortality data, specialty drug dispense, patient registries, academic medical centers, and even non-traditional healthcare data, such as social determinants of health. In the next section of the webinar, we will go into a deeper dive on a longitudinal research study conducted using BHI data, which highlights the intersection of behavioral health with major chronic health conditions. For this, I'll turn it over to Farid, who will present on his research using BHI's data.
Thanks so much, Sue. Thank you all for being here. Thanks for spending time with us today. Let's jump right in and allow me to lay the framework around some of the insights I'll share on chronic conditions and behavioral health today. Chronic diseases, chronic disease in America. Clinically, they are incurable, but preventable and manageable. And they're the leading cause of death and disability in the United States and the leading driver of the nation's $3.8 trillion in annual healthcare costs. As per the CDC, 6 in 10 adults in the US have a chronic disease. That translates to almost 200 million Americans with at least one chronic condition. Now, 4 in 10 adults in the US have 2 or more chronic conditions. These chronic conditions make up 75% of aggregate healthcare spend, approximately $5,300 per person annually. And research shows that behavioral health issues and chronic conditions co-occur. Chronic conditions can lead to behavioral health conditions, and behavioral health conditions lead to chronic conditions. The behavioral health implication is furthered by the Health of America reports produced with Blue Cross Blue Shield Association on major depression, where it was seen that there is an exponentially higher cost when co-occurring with chronic conditions, a decline of about 27% in overall health in individuals with major depression, and a reduction in future healthy life expectancy of about 9 years. So a question was raised, which resulted in the insights I will share with you momentarily. And that was, since research states that a behavioral health concern can lead to a chronic condition due to specific behavioral behaviors, such as poor eating habits, lack of physical activity, substance use, socioeconomic status, and a chronic disease can result in behavioral health issues such as poor eating habits, lack of physical activity, potential substance use. What about those folks that have multiple chronic conditions? How do they compare? Research suggested that chronic conditions lead to increases in behavioral signs, symptoms, conditions, and the impacts to healthcare costs are exponential. And so we tested this theory. The descriptive analysis I'll share with you looked at various chronic conditions. We looked at hypertension, diabetes, and then combinations of those chronic conditions and various behavioral health conditions, major depression, anxiety, and combinations of those behavioral health conditions as well. To be able to overview the insights we gained in the analysis, I'm going to limit sharing cohorts. So we'll stick to one chronic condition with the behavioral condition. And that one chronic condition is hypertension. The behavioral condition will be depression. And we'll also come up with the other cohort, which is multiple chronic conditions. That'll include hypertension, diabetes, and coronary artery disease. Now, the total population selected averaged annually at approximately 25 million members at our disposal. And the selection criteria we used was, we looked at a study year period, a 5-year study year period from 2013 to 2017. I kind of went a little farther back. We have it up to date, but I pulled out 5 years, which was 2013 to 2017. I didn't want to include 2020 for intents and purposes of this presentation. But members aged 18 to 64 years old, primary to BCBS, residing in the States. They must have had medical and pharma benefits. They did not have to be continuously enrolled, included professional and facility claims, and only paid claims, included only claims with allowed amounts greater than $0. And I know I'm getting a bit technical, but for those, just for the data that we're going to share, it's better for everyone to understand the background. We did have an exclusion. Members with behavioral coverage were carved out. So let's get into the data and let's see what the results look like. And I'm going to start off initially with period prevalence. And we're going to look at the single chronic condition with the layer of the behavioral health added on. Now, we could slice and dice the data in different ways, look at various attributes, and I'll share some points on regional differences as well, but I'll be speaking mostly and analyzing gender and gender variation as well. Now, these graphs help examine the trends of the proportion of people or persons with a particular condition that occurred at any time during a time interval, which is the period prevalence. When examining hypertension alone over 5 years, we note the increase in prevalence of hypertension in the study population. Ever so slightly, but still an increase. And higher in males than we see in females. And with the females, you actually see a decline in that prevalence over that 5-year period. Now, when examining hypertension and you add on that behavioral health layer of depression, major depression over 5 years, we note prevalence rates flipping. Females now are higher among the male and female cohorts that we're looking at, and trending higher across the study period. What's interesting to note is that once you add the depression layer to the chronic condition, you do see a steeper increase and spike across the board between females and males in prevalence. Also, what's interesting, and just a clinical note, as far as females go, it's researched and it's known that they are more likely to go and follow up for their healthcare and go to their routine exams and such. And I think that'll play a factor in some of the insights we're going to gain shortly. When compared to multiple chronic conditions, in examining the multiple chronic conditions of hypertension, CAD, diabetes, the prevalence for males more than doubles that for females, and the margin progressively widens. Again, add on that layer of depression, and seen in this member population, there's a rapid increase year over year with prevalence rates staying higher among males. So as you tie up this information, you start looking at the prevalence rates, what you realize is as soon as you add on for chronic condition, a single or multiple chronic conditions, and you add on that layer of behavioral health, you start seeing more of a steep peak, steep spike or increase in the prevalence rates across males and females as well. Now we can further dissect this data and look at, okay, what regions are more prevalent? And the U.S. Department of Health and Human Services divides the country into 10 regions. In applying the regional variations and understanding those 10 different regions and looking at hypertension and depression, we note that region 4 with the following states are consistently at higher prevalent rates. And region 4 includes southern states such as Florida, Alabama, Georgia, Kentucky, Mississippi, and the Carolinas. And what's interesting is that across the board, hypertension only or hypertension with the layer of the behavioral health, the same region has that increased or that number 1 prevalent rate, and then number 2 being region 6. Now, in applying the regions to multiple chronic conditions, very similar. We note that region 4 remains the top spot for the prevalence of those multiple chronic conditions of hypertension of a member who has hypertension, coronary artery disease, and diabetes. And when we look at region 6, which comes in second, region 6 includes Arkansas, Louisiana, New Mexico, Oklahoma, and Texas. And what's interesting is hypertension or the multiple chronic conditions, but once you add on that layer of behavioral health, you're still seeing the prevalence rates in the same region. What does that identify? That identifies the possibility that there's further research to be done specifically for those regions as far as why those prevalence rates are so higher there than other regions. And the other part is something that Joe mentioned earlier. Maybe we should slice and dice it and see social determinants of health and understand what are the different barriers and what that might be causing that spike in prevalence. And we can speculate and research further and dig into these regional variations. Now, this is this next topic, specifically transitioning now to cost trends. Based on what we understand about the year-over-year increase in the members with conditions reviewed specifically with behavioral health, when we start examining hypertension alone, we note a similar decrease in cost year-over-year for both males and females. What's interesting is, of course, you add on that layer of behavioral health and you automatically see the spike in cost, right? So at the end of the day, there's an understanding. As soon as you add on that behavioral health diagnosis, what you're going to end up seeing is this kind kind of spike in cost. However, in the year-over-year analysis that we had done from 2013 to 2017, when you start to partition out the impacts and start looking at the cost difference across the 5 years and the change, there's some similarities. When you're looking at hypertension alone, what you note is, the cost difference between 2013 to 2017 for both male and female is somewhat similar. We're looking at about $700 per member per year. But we see this declining 5-year percent change, right? We're looking at almost, for females, it's about 10%, and for males, it's 13% decrease in the cost. And what are the reasons for that? And I'll discuss that in a second. When you start looking at hypertension and depression, what you see is a more drastic decrease in per member per year cost difference. For females, you're looking at about $3,300, and in males, you're looking at approximately $3,600. And in the 5-year percent change, you're looking at an average of about a 28% decline. So we're talking about, prevalence rates going higher year over year, but we're looking at costs that are coming down. However, we understand now, as soon as you add on that layer of behavioral health, those costs increase. Certainly over time, you're seeing them decrease. Why is that happening? Is it physician awareness? Physicians are now more aware of mental health and behavioral health during this period of time, or as time progresses. We know that there's been a lot of attention. We know that there's been a lot of research, and we know that there's a lot more programs to support these type of patients and members. Sorry, I have a bad habit of referring to members as patients at times. What's interesting is, as we go to multiple chronic conditions, the first thing you easily see is the increased costs. It's this spike in cost as compared to the multiple chronic conditions. So you have hypertension, coronary artery disease, and diabetes, and then you add on the layer of depression again, and this exponential increase in spike in costs that's occurring per member per year. You note the drastic difference in males specifically when it comes to the added on layer with depression. Now, when examining multiple chronic conditions alone, you note similar margins and trends between the males and the females. But when adding depressions, males are at the lowest change percent year over year. So speaking a little bit about multiple chronic conditions on the left here, the per member per year difference for females, cost difference, has been $6,500 with 5-year percent change of almost 20%, with males being $3,900 and with a 14% decrease. And then you have hypertension and coronary disease and diabetes and depression, where you note that female costs difference has come down almost $20,000 with a 40% impact, 5-year percent change. And then for males, it's been about $11,500 with about a 20% change. The reason why I bring this up is over time, even in 2013 to 2017, with all this awareness, what we're noticing is that the cost is decreasing, that it's being paid attention to, that someone has depression or someone has a behavioral health condition, and they have multiple chronic conditions, or they have a single chronic condition. And they're being addressed through programs, they're being addressed through physicians, they're being addressed through support areas, and just simple awareness of what's happening. Now, females are seeing a larger cost difference change, a bigger impact with costs coming down across the board. And that has a lot to do with the fact that it's, again, as I had said earlier, that females are known to be more attentive to their health, to be more attentive to their healthcare. And that's researched and studied, and stats explain that as well. But moving forward to other cost drivers, let's talk a little bit about these utilization trends, and let's talk a little bit about inpatient admissions and ER visits when it comes to chronic conditions and chronic conditions plus behavioral health. Now, let's stick to inpatient stays for a second, because across the board, you're going to see very similar changes occurring. It's clear that depression adds an extra layer across inpatient admissions. You see that very clearly when you see females and males with hypertension alone. 59.9 per thousand or 39 per thousand. And then with the added layer of depression, you're noticing the 84.9 per thousand and the 89.7 per thousand. So what you notice is that when you add on the layer of behavioral health, again, you have automatically an increase in a spike in these inpatient stays. And that's understandable. I think clinically it's understandable as well. But of course, with that added layer, with that spike, of course, that's going to drive costs. Of course, that's going to drive many different things that need to be addressed, that physicians need to address, that payers need to address, providers need to address, pharma needs to address. Also, when it comes to multiple chronic conditions, and you have multiple chronic conditions with the layer of depression, again, you're seeing that spike in inpatient stays. It's the same pattern you see across even with ER visits. When you get to hypertension and hypertension with behavioral health, and multiple chronic conditions with the behavioral health. So it's clear depression is adding an extra layer to increase ER visits, to increase IP stays. And even though the increase is seen across gender, males see a marked increase. Again, going back to that concept of, we're noticing females being a little bit more controlled as these IP visits and ER visits increase. However, males are by far leading in the marked increase in those areas. So to sum up what we're talking about, we realize that when you have chronic conditions and you add the layer of behavioral health conditions, you automatically are seeing higher costs. You're seeing higher cost drivers such as IP stays and ER visits. On top of that, you also see what regions we were able to share, what regions are actually where you see the higher prevalent rates. And you can then further examine and dig into those regions and understand what are the reasons why that might be occurring through the data that we have and through the longitudinal studies that we completed. So moving forward, when you look at even those prevalent rates, what we start realizing is even though prevalent rates are going up when it comes to just a chronic condition, when you add on the behavioral health, you see a more steep increase in those prevalence. And so the chronic conditions causing issues where it could lead to a behavioral health diagnosis or behavioral health condition, leading to behaviors and issues that could potentially cause chronic conditions. But I'm going to move into areas now at this point outside of descriptive analytics, knowing what we know from our data and talking a little bit more about some of the use cases. Joe had mentioned earlier regarding the predictive analytics that we complete and the modeling that we do. Well, we're taking chronic conditions and we're taking multiple different areas, but using chronic conditions as an example, we're aligning impact areas and root causes with automated intervention recommendations. What we have here is a specific persona. We're able to identify, because of the longitudinal amount of it, the longitudinal data that we have, we're able to identify what does a diabetic look like. And once we know what a diabetic looks like, we're able to then further model and predict who might be at risk for an acute flare. And once we're able to identify who those people are, running those variables through the modeling of the predictive model, then we're able to become a bit more prescriptive. What are those areas of impact that might be the reason for the acute flare? What are those potential root causes for those areas of impact? So when we start looking at chronic condition, example being acute flare for diabetes. So you have diabetes, you have an acute flare. The areas of impact that are noted based off of the models that we've had, we note that poor condition control leads to acute flare. We note that poor continuity of care leads to acute flare diabetes, poor medication adherence. But we go further. As stated previously in the descriptive, the predicted potentially avoidable admits and ED visits. We know that if someone is in an IP stay or is going to the ER visit, that potentially is reason for acute flare as well. And could we potentially predict, can someone get more support or be part of programs or part of other care management programs where they could potentially then not need to rely on an ER visit or an IP stay because they're being managed appropriately by their primary or their physician. But getting back to the persona, again, what are the root causes? Let's take an example for poor medication adherence. What you see are potential root causes such as, we talked about this a little bit earlier, behavioral health diagnoses. We understand that behavioral health diagnoses cause specific issues where people could potentially not take their medications appropriately. We know that polypharmacy, multiple meds can cause poor medication adherence, forgetfulness of being able to take 7, 8 meds at a time. High copays, we understand that as being root causes. And then we, of course, have recommended interventions, that recommended automated interventions, such as social support needs evaluation or mail order pharmacies as examples. So it's interesting how all of this ties in. Even with our descriptive insights, we learn about what behavioral health can do to chronic conditions, and then we're actually identifying those chronic conditions and what those flare-ups are, and identifying that behavioral health also is one very important root cause for multiple issues that can occur. But in the same process, we're looking at many different variables, not just one. Behavioral health is just one. We're looking at all these different variables that then feed into these different areas of impact and these underlying root causes as well. So let's move on to something a little different now. I'm gonna share another use case, not specific to chronic conditions, but definitely a behavioral health topic that's currently being discussed in many different areas. As a physician, as somebody who's worked on some COVID analytics and working on COVID analytics at BHI, I get pretty excited when we have these type of findings that our data speaks to what we hear about out in the outside and what's happening during this pandemic. Specifically, let's talk a little bit about COVID first. We've been fortunate that because of our data, we've been able to create COVID member journeys. COVID member journeys being that we're able to track in all different areas. If someone was tested positive for COVID, if they ended up in an IP stay, if they ended up not in an IP stay, what are those complications that have occurred afterwards? In a non-IP stay, in an IP stay, what have ended up as sequelae? We can track a COVID member and their full journey from the time that they were tested positive to even being able to see how many times they were further tested and if they've potentially ended up with COVID again, and seeing if they've been tested over a second, third, fourth, fifth time, and if they've seen a COVID diagnosis again. But for all intents and purposes, for this use case, I'm going to stick to a very specific member, and that member is the non-severe COVID patient. Who is that non-severe COVID patient? How do we define it? We define it as a COVID patient, somebody who's diagnosed with COVID, who had a positive test, who did not require an inpatient stay. So this person has COVID, he's able to move around, he's not that ill. It's your non-severe patient. And then we're looking at their diagnoses 1 to 6 months after their first COVID diagnosis, and which we're qualifying at this time as a sequelae. As more data comes available, and as we understand more about COVID, and as we understand more about how the data is speaking to us, that definition could change. But for the time being, we're looking at 1 to 6 months. Now, we're identifying specifically, and we're looking at after that COVID diagnosis, what behavioral health diagnoses might have come up in those 1 to 6 months afterwards. And for that, we're using our episode of Care Grouper, and we're looking at the top 3 behavioral categories, and that is anxiety, depression, and stress disorder. And what we note is in the non-severe COVID patients, 15% of those patients ended up with a BH, behavioral health diagnosis, anxiety, depression, stress, in the 1 to 6 months after being tested positive, after being diagnosed with COVID. Now, are these diagnoses new? Are these new BH diagnoses? Are these new behavioral health problems? We don't know, but luckily we're able to search back. We can actually go 6 months back, 2 years back, 4 years back, 5 years back, and it helps us. It helps us understand, has this person had any kind of a history of BH, behavioral health? And I apologize, I keep saying BH, but hopefully everybody understands I'm talking about behavioral health. And when we look at a 6-month look back period out of those 15%, what we note is 49% of those patients did not have a BH diagnosis in the last 6 months. In a 1-year look back, 43% of those patients did not have a BH diagnosis in the 1-year look back. And in a 2-year look back, we see 38%. So on average, what we're seeing is approximately 40% of the members we're identifying didn't have a BH diagnosis in a 2-year period prior to. So the question becomes, how we can dig into this further. And we'll continue our analysis on that with our COVID analytics, and we'll continue to move forward in that area, and which hopefully we can discuss at some other point. So let me transition a little bit to social determinants of health and just quickly overview social determinants of health. I know Joe spoke a little bit earlier about how we could use social determinants of health in our analysis. We are able to apply this type of data specifically to some of the insights that I shared today. Specifically, when you talk about access to care, distance to food access, distance to PCP, emotional behaviors such as behavioral health disorders, health impacts, advanced age, member disabilities. How about dependence with disabilities? All of these different social determinants of health we can apply to our analytics, and we're able to then research further, of course, for any kind of disparities that might be there from a social perspective. I think I'm short of time, so at this point, I appreciate you listening to me. I'd like to transition back to Sue, and thank you for listening.
Thanks so much, Fareed. So that includes our prepared content, and we will dive into some questions at this time. To submit a question, you can input into the Q&A box in Zoom. There's a small icon at the bottom of your screen. So let's start with this question. Are all of the Blues feeding data to BHI? Are there any restrictions on what is being received? For example, are there certain states that are not contributing or contributing less than the totality of their data? And Joe, I'll ask you to answer this question.
Very good. Thanks, Sue. We have most of the Blue Cross plans as contributors now. Anthem is not in our pool of data that we commercialize yet. Hopefully that will be added at some point. We started years ago with our original 18 owners of BHI, and we quickly added most of the remaining Blue Cross plans as contributors. As I mentioned in one of my slides, we get their local and national members. So if you take Indiana's example, it's an Anthem state. We have 23% penetration of the commercial population in Indiana, even though Anthem's not a contributor. A lot of that population might be auto workers covered by Blue Cross of Michigan. They might be people who live in Indiana but work in Chicago and covered by Blue Cross of Illinois. So that mix of what they do contribute really helps us in many markets of that type. And as far as types of data, again, I try to emphasize, think of us as a commercial population for now. We have a growing pool of Medicare Advantage data, but we don't commercialize that yet until such time we have a broad enough pool of that type of data.
Thanks, Joe. Another question, what examples of social determinants of health data is BHI including in your data? Fareed, why don't you answer that one?
Stu, I appreciate that. It's funny. I think that's what I just rushed through at the end. So I appreciate the question. Specifically with social determinants of health, some examples that we could share are, that feed into our determinants. It's financial, limited income, cost barriers, environment, dependence with disability. We're looking at skills such as limited education, health impacts. I mentioned earlier, member disabilities, advanced age. Also, emotional behaviors. We talked about behavioral health disorders, minority areas, substance use, and we use ACS survey, USDA food access to understand where those food deserts might be. We're also looking at getting RX deserts and compiling that data for our social determinants of health, where you'll be able to realize if there's a specific medication desert, if there's a specific chemotherapy desert. Also using claims data to inform factors of great value, such as the distance from PCP and understanding limited mobility and social support issues as well. Hopefully that helps.
Thank you. Another question, probably best position for you, Fareed. Have you looked at trends in medication use for depression, pharmaceutical data, like the opioid epidemic? Will there be an overuse of depression medication? Any long-term effects? If you could speak to that, that would be great.
Yeah, no, I appreciate that question as well. So we have looked at trends in medication. I wouldn't be able to speak to it off the top of my head at this time, but we've done various analyses into opioid epidemic and what was occurring with opioid abuse. And as far as long-term effects, we really at this time specific to COVID-19, we really haven't gone into that. I think right now with the data that we have, we're really trying to analyze what are those areas that we need to dig into. Behavioral health being one of the bigger ones that's come up, of course, over time. That was being spoken about in the news and media and in studies as well and research articles. And what we're doing is we're going to further be digging into that. We're further going to be digging into medications for these behavioral health conditions that are showing up. We're going to be further digging into what's happened with abuse of medications and substance use and abuse as well, specific to COVID-19. However, we do have previous analyses where we've done on opioid epidemics and looking at medications, antidepressants and such as well.
Thank you, Fareed. Question for Joe. Do you offer analytics support along with a data license, or can you also provide a full analytics study instead of a data license?
Yeah, hey, that's a very good question. I meant to cover a little bit of that in my presentation, but depending on the resources internal to our customer or partner, we can help along that spectrum. A lot of our clients have a great analytic team of their own, and they just want to get their hands on the right data. And even in that case, we don't just hand over data and disappear. We provide ongoing help and interpretation of if you're trying to tease out ER visits from a facility claim, how would we do that? So we'll give you tricks of the trade on how we use our own data. But we have some hybrid models where somebody's doing a study, but we'll be heavily involved in the study design development. And then we have some projects where we do the entire analytic study for a customer and help them with their results from that study if they're trying to do a publication or whatever. So yeah, anywhere along that spectrum, we can help out.
Great, thank you. A question for Fareed. The data analysis on depression with chronic conditions was very insightful. Have you looked at anxiety diagnoses as well?
I appreciate the question. We actually did. We did look at anxiety. It was, I pulled apart major depression because major depression, along with those chronic conditions, it was more visible. You could see it a little bit more easily in the graphs and in the data of what the true impact was. With generalized anxiety, we saw the impact and there was increase in costs and other things as well, but not as drastically as there was in major depression. So I opted to overview major depression as opposed to anxiety, but we see similar patterns, but just not as steep of an increase in costs and such as you see with major depression.
Okay, great. Well, that's going to conclude the Q&A portion of our webinar today. Thank you everyone for joining. Thank you especially to our guests Joe and Fareed from Blue Health Intelligence for sharing your insights. If we didn't get to your question today, we will be following up with you separately, and we'll be making this webinar recording available next week. We'll send out an email to all the registrants once that is available. Thank you.
Thank you all.